Good afternoon, everybody. Happy Thursday, and welcome to the Oregon Center for Nursing's webinar in partnership with the Oregon State Board of Nursing. For those who don't know me, my name is Jana Bitton. I'm the Executive Director of the Oregon Center for Nursing. And again, thank you very much for joining us on this really important topic, a very timely topic, and something that is coming, that was happening before, and it's really happening now. It will continue to happen after we're done with the pandemic. So thank you all for coming. Just wanted to let you know a little bit about the Oregon Center for Nursing for those people who are not familiar with us. The Oregon Center for Nursing is the state's nursing workforce center. Our job is to facilitate research and collaboration for Oregon's nursing workforce. So we study a lot about what is going on with the workforce, how many nurses we have, how many nurses we need, how many nurses are in school, how many nurses are coming in from out of state. And then we take some of the information that we learn from that and we collaborate and convene people together so that we can actually address some of the problems that are found. And then we also promote nursing and advocate for nursing as a profession. So this particular presentation is coming from some discussions that we had at our Friday huddle, and this is why we've asked Ruby Jason, who is the Executive Director from the State Board of Nursing, to give us his presentation. A little bit about Ruby. Ruby graduated with a Bachelor of Science degree from the University of Texas Health Science Center in San Antonio in 1984 and received her master's degree in nursing administration from that same institution in 1989. Ruby started her career in the neonatal intensive care unit as a staff nurse and a charge nurse. After obtaining her master's degree, she's been a manager or director over pediatric neuroscience, pediatric outpatient clinics, adult critical care, pediatric and adult emergency departments, quality management, case management, and also as respiratory therapy, diagnostics, and therapeutics, as well as a house supervisor and a research nurse. She has worked in multiple states and has worked for 6 different healthcare systems, including faith-based, for-profit, not-for-profit, managed care organizations, and academic medical centers. Her previous position before becoming the executive director was the division director for children's nursing at Dornbecker Children's Hospital / director of women's services at OHSU. She's certified as a nurse executive at the advanced level by the American Nurses Credentialing Center and is a fellow of the Institute of Regulatory Excellence for her study about the risks, threats, and challenges of reporting impaired practice to the board. She's been executive director at the state board since February 2014, and she knows the Nurse Practice Act like the back of her hand. So today, we've asked her to give us a little presentation about assigning tasks to unregulated workers, but in addition to that, we also want Ruby to share, if you have any questions, not necessarily just related to this, but if you have any questions to the Board of Nursing, this will be an opportunity for you to ask those questions too. And so with that, I'm going to turn it over to Ruby.
Okay, I'm not sure whether knowing the Practice Act backwards and forwards is a compliment or a pity party, but yeah. Okay, so this is about assigning and supervising unregulated healthcare staff. All right, this is not new. This is how it has been for quite a while, and as Jana said in her presentation, that this is something that is becoming more and more prevalent. We are looking at hospitals wanting to bring in augmented staff to work alongside nurses, and what does that look like? We've also had hospitals ask us if they could take their non-essential staff, such as speech language pathologists, etc., and can they be educated to also do unregulated tasks? And so the answers to all of that hopefully will become clearer when we finish this presentation. Again, at the end of this presentation, I invite any questions that people might have. This is a very difficult time, fast moving, everyday answers change, but I will give you the answers that are valid today. All right, what does it mean to be regulated or unregulated? The old term was licensed or unlicensed, and we're trying to get away from that because there are multiple caregivers now that do not have licenses yet are regulated by a board or a commission of some type. So we'd like for people to, when they think of people that are unlicensed, really think of them as unregulated. So if you are regulated, the standard for your education, licensure, or certification requirements and your adherence to practice standards are under the legislative authority of a board. If you are not regulated, it is the employer that describes what tasks you can do based upon your job description and based upon their competency validation of your skills. In other words, the employer takes the total risk of assuring that the individual who is unregulated, who has been given some tasks of patient care to do by the organization, that they are competency validated. There is no board that you can go to. Okay. Next slide, Kelly. Can you do that? Okay, thank you. What does this mean? First of all, unregulated individuals have no scope. You can only have a scope if you are under the purview of a board and you are considered licensed, like an RN or an LPN, an APRN. They are licensed, and scope grows as you grow. Scope grows as you become more experienced and as you have more education, work in different areas, etc. What you could do as a new grad certainly isn't what you can do now. However, an unregulated individual has no scope, which means they cannot grow beyond the assigned duties and what is competency validated by their employer. Even if they stay in that job for years and are very, very good at what they do, they are still bound by the parameters set by their employer. So the question we usually get is, are CNAs licensed? Now, CNAs are not licensed, but they are certified by the board as meeting a minimum education requirements, and they have authorized duties as prescribed in the Practice Act. These individuals are considered regulated, but they don't have a scope because, again, no matter how good a CNA may be and how long they may be in your workforce, they can never go beyond the authorized duties that are listed in the Practice Act. So again, scope means you can grow in your duties and tasks and interventions and knowledge base and apply your new knowledge base in your continuing education. But if you do not have a scope, this is the box you live in, and this is the box you're going to live in forever. Now, the CNAs, again, are an example of those individuals that are certified rather than licensed, but they are regulated because if we receive a complaint against a CNA, we could discipline their certification, take them out of practice, revoke, suspend, or require them to have some education, continuing education to remediate their practice. So the thing about unregulated staff is there's no public recourse, which is one of the reasons why licenses and certifications exist, that the state is taking responsibility that says to the public, these individuals have met the minimum criteria for safe practice, and the state stands by those requirements. And if those individuals don't live by those requirements, then those individuals don't get to practice under that certification or that license. However, for unregulated staff, there is no public recourse. The employer can fire them, but they can also then go down to the hospital down the street and say, hey, I'm an experienced OR tech, ER tech, whatever, and I can go ahead and they can go ahead and get another job, and the public will never know why they were terminated from their last position or whether or not they even practiced safely. Okay, next, Kelly. Thank you. So what is the difference between delegation and assigning? So assigning is, and I'm going to read this to you, even though I know all of you can read, but I want to make sure that you understand that the wording between assigning and delegation has some significant distinctions. First of all, assigning means directing and distributing within a given work period, a shift or a day or whatever, the work that each staff member, no matter who is in that environment, staff members such as a CNA or a ward clerk or another LPN or an RN, each staff member is already authorized by license or certification or organizational position description to perform. That means somebody has said, this is the stuff you can do, this is the stuff we're not going to allow you to do, this is how we've competency validated you, and now you can go ahead and do those things. So either a board has said that or an employer has said that. So the issue with unregulated staff is the employer has said you can do this, and for the boards, the board has said CNAs and nurses can do this, which means that whoever is giving them direction is assigning them that task, because that person who is assigning the task already knows that that individual can do that task successfully. So what's that in delegation? Now, I know a lot of you out there, I know I use the term delegation in my practice with CNAs, but that word does not really apply to any place where nursing service is present. Delegation is a process where an RN, and only an RN, may utilize in a community-based practice setting to give an unauthorized licensed assistive person's ongoing performance of a nursing procedure for a specific client while retaining accountability for the outcome. This means that in a community practice setting such as an adult foster home, as in assisted living, etc., that an RN goes in there, the patient has orders for sliding scale insulin or wound vac or some other intervention, and there is no nurse to give that particular intervention to, because that patient might need that round the clock, but there is no nurse there around the clock. So the nurse then assesses the patient, assesses the unregulated assistive person, and that should say unregulated, I'm sorry, it should say unregulated rather than unlicensed, assistive person, to go ahead and perform that specific intervention with that specific client only, but they do so under the license of the nurse. So in this case, under delegation, the individual actually works under the license of the nurse, not so under assigning, because the board or the employer has already said that these individuals are competency validated to perform these interventions. So next. Okay, so here are the significant differences between delegation and assigning. Occurs in acute care settings. Assigning does occur in acute care settings, but delegation does not. Remember, delegation is specifically defined under the Practice Act as being in a community-based care setting only. The RN must teach and validate competency of each task for a specific patient. Under assigning, no, the organization takes the accountability, provides nursing staff a competency validation list and approved duties. This is something that we see regularly, that acute care organizations, some of them do it really well, some of them don't really understand that the nurses need to have the knowledge of, if I'm working with an MA, or I'm working with an OB tech, or I'm working with an ED tech, what can these people do? There needs to be a competency validation list that has been published by the employer saying, we will go ahead and take the risk that this person can do this safely. So in an organization, so no, the individual RN doesn't teach and validate, but in the delegation setting, yes. In the task remains under the license of the RN for successful completion. For assigning, no, it is the organizational risk as long as the nurse knows the task is an appropriate assignment for the patient's acuity and skills of the staff member. This is also something that nurses really don't understand. In a lot of places they will work in parallel, but it's actually that the nurse should not assign someone that they are already authorized to do unless the nurse has validated that there is a match between the patient's acuity level and the skill set of the unregulated individual. For example, somebody is starting on vasopressors and their blood pressure is labile, it's all over the map. Is that someone that should have an RN assess their blood pressure, or is that someone that an unregulated individual can go ahead and measure the blood pressure, and how is that nurse and that unregulated individual working together and communicating the status of the patient? So under delegation though, yes, the task remains under the license of the RN for successful completion. Next, please. Okay. What happens if I assign someone that I know was not competency validated or part of a job description? So here's where there is a slight overlap, but I'm hopeful that you will avoid this slight overlap between delegation and assigning. If you are a nurse working in an acute care area or in a clinic area where there are unregulated staff, and this person has worked with you for a very long time, and they're very smart, and they're wonderful, and you say, look, I know that this really isn't in your job description, but I want you to go in this patient room and do X, whatever it is. If the individual has not been authorized by the employer and has not had competency validation, or the patient's conditions require the task be completed by an individual who can truly assess the outcome, not just gather data, but assess the outcome, then the task does remain under the license of a nurse, who then takes accountability for the outcome, including any negative outcomes. So in other words, that if you decide that you trust this person and you are going to give them a task that neither the employer has authorized nor have competency validated that individual for, then it does come under your license. And I would strongly advise nurses not to do that, because again, if that individual, that patient has a bad outcome, not only will that individual probably be fired by their organization, but you could face an investigation by the board for assigning a task to someone who does not have the competency validations to successfully carry out the task. And that would be OR 851-45-0703B. And if you want to look at exactly what delegation does include, it is found in Division 47 of the Practice Act. And I believe that's it for me. So I would be very happy to answer any questions.
Great, thank you very much, Ruby. I really appreciate that. I know that I've had this conversation with Ruby a lot about the difference between assigning tasks and delegating tasks, and it is more than just using the right words, because they mean very, very different things. And so I appreciate making sure that we have that clarity, especially when there's so much talk about now about expanding the workforce to include some unlicensed, or excuse me, unregulated workers. So I appreciate that. So for everybody who wants to answer, this is now open, it's open mic time. So if you've got some questions that you have for the board, either about supervising unregulated, assigning and supervising unregulated healthcare staff, or if you have other just general questions from the board, we will keep Ruby here as long as she's willing to stay.
So the first question comes from Rachel Miles, and she is still struggling with the difference between delegation and assigning, and is wondering, Ruby, if you could provide a couple of more examples that would demonstrate the difference.
Okay, well, first of all, delegation only occurs in community care settings. That is the legal definition of delegation under the Oregon Nurse Practice Act. So if you are in a place where nursing service is present for the entire time the facility is open, like if you're in a clinic and there's always a nurse there, or a LIP, physician, APRN, that sort of thing, or if you're in an acute care setting, there is no delegating. There's only assigning and supervising, all right, to an unregulated healthcare person. And that includes your medical assistants. There's a lot of thinking out there that medical assistants are regulated by the medical board, and they are not. Nobody regulates them. So they are also considered unregulated healthcare staff. So assigning simply means that that individual that you are asking them to go and do a certain task, the organization has already said, yes, this is within their job description. Yes, they have been competency validated. And then the individual supervises that the task has been carried out. But if the individual is competency validated and the organization has authorized them under their job description to perform these types of tasks, then if something goes wrong with the patient and because the individual did not do that task correctly, it is not under the license of the nurse. It is the risk of the organization. So that person, when you assign someone, they are not working under the license of the nurse. When a nurse is in a community care setting where there is no RN available, and they delegate a task by both teaching the task, such as doing capillary glucose measurement and giving sliding scale insulin, that individual works under the license of the nurse as long as the individual does exactly what the nurse says and the nurse has left written instructions. If there's an error, then the nurse does have some protection. However, delegation is about, I'm taking someone, I'm responsible for their teaching, I'm responsible for making sure this patient stays stable, and it's one duty to one patient. Whereas assigning is in a workforce setting where there are nurses available, it now becomes an assigning because the organization is taking accountability because there is no board involved in that unregulated individual. That includes your MAs, and it also includes your ER techs. And that is because if your ER tech is an EMT or a paramedic, their scope of practice stops at the door. That is an outpatient scope of practice, not an inpatient. They may come with a set of skills, but the organization is still responsible. And if an ER tech, who is also a paramedic, makes a mistake in the ER, there's no board to report them to because they are not fulfilling their scope as an EMT or a paramedic. They are an emergency room tech. So under that case, the person still isn't licensed. It does not fall under the license of the nurse. The individual is regulated by their employer. Does that answer your question?
Thank you so much, Ruby. Gretchen Cook from the Board of Nursing has also typed in and is reminding us that the board also has prepared an interpretive statement on the delegation process and assignment and supervision. And I'll try to see if I can get a link to that I can post into the chat box for our entire audience here. We have several other questions that have come in this time. Brenda Umalap from Salem Health is wondering if during the pandemic, there's an opportunity to use assigning to hire second-year nursing students to help with nursing tasks.
Yes, actually, nursing students, both at the ADN level and in the ADN level and at the BSN level, if they're in their last semester of nursing school, that they can go ahead and be brought in. They are allowed to go ahead and use those hours as their clinic hours. The reason we don't want to go beyond the 4 years, the last semester students, is because the majority of the kind of tasks they can do will be, they have already have done those. And at a time like this, there isn't really a lot of supervision. And what we don't want are nursing students who really have not yet had a good grounding in theory and in competency in terms of their clinical practicums out there practicing. Because at the end of the day, the board still needs to think about what is safe for the patient. And sometimes just putting bodies into the workforce is really not the right idea. There is a statement on our website that talks about how the schools and the organizations can work together to talk about bringing in students still under the guise of being a student and also with some type of worked out supervision. It doesn't necessarily need to be a faculty member, but somebody has to take accountability because these individuals are still students. But we are very concerned that, again, if you go beyond or if you go looking at first and second and third semester nursing students, they still have not had all the skill set to be helpful. So we are limiting it to the the last semester of nursing school if they're still in there. And then they can also graduate on time because right now a lot of people have closed the clinical practicum doors, and some of these people may not graduate in time if their school cannot find a way for them to maintain the same level of education as if they were able to go to their clinical sites. So the more senior nursing students are able to go back to their clinical sites and be an augmentation to the staff, the better it's going to be for them and the sooner they can graduate.
Thank you, Ruby. Another question that was asked is, are nurses who are not able to take the NCLEX going to be able to assist in filling the need for nursing during the surge if necessary?
Okay, so we have had no reports yet of people not being able to take the NCLEX. The NCLEX is being offered in Salem, Portland, and in Medford, with other places coming on live. We did have a conference call with the National Council on State Boards of Nursing, who actually own the NCLEX, and they have it administered through their partner, Pearson VUE. And Pearson VUE is opening more and more sites. They have also abbreviated the NCLEX exam with still making sure it's psychometrically sound, so that people can get through the test center quicker, and because they're only going to take a certain amount because they have to clean everything in between sessions. So the NCLEX, I believe, has gone down to about 60 questions, which again, they have psychometrically validated that. Now, that's today. As you know, graduation season's coming. We do not know whether or not NCLEX will be totally up and running before this time. The issue is that Oregon does not currently have a GN permit. And again, if you have someone who has a nursing license already or can work under a GN permit, is there going to be enough orientation and supervision of these people to assure patient safety? That said, the board is committed to making sure that if there is a huge backlog of graduating students who can't get to the NCLEX for, a couple of months because of the demand and the volume and the number of available seats, we are going to be revisiting the GN issue. I am asking my a GN permit issue because I know when I was new, I worked under a GN permit for months because it took that long to get the NCLEX exam results. So we are looking at that. I have asked my staff in licensing to keep tabs on how people are doing and how they are getting scheduled. And as of today, there's not any issue in somebody being able to schedule the NCLEX in a reasonable amount of time.
So we have a question here from Terry Judd in Wallowa County, and she says they have 4 nursing assistants who are waiting on results related to their certification from OSBN. And while they're waiting for their results, are they able to put these people to work as unregulated staff after setting up a competency training?
Nursing assistants are a little bit of a different wrinkle. So the board is the one who regulates the training programs and the testing for nursing assistants. The individuals that are nursing assistants, most of those testing requirements are federally regulated. Now, DHS is working on a process that will allow them to stay in nursing homes longer before they are getting regulated. However, if you want to use CNAs before, they will be considered unregulated individuals, and again, the employer takes accountability for competency validating them. So the answer to your question is, if you're going to use them in acute care, you have to use them as unregulated, not CNA students, not CNA almost. They are considered unregulated, and everything I said previously about regulated and unregulated is applicable to these individuals.
Okay, thank you. Another question that has come in is, how are the surge workforce's competencies, such as CPR, being addressed during the crisis pandemic period?
Things like CPR, PALS, ACLS, those types of things are not under the jurisdiction of the board. Those are employer-required additional certifications, not board certifications, but task certifications. So if an employer says you have to have CPR, then the employer is going to have to provide that or send someone to some place where they can get that, although that is pretty not there right now. So the board has no jurisdiction over CPR, PALS, TNCC, any of that. That is employer specific only. And of course, I'm sure it's Joint Commission specific only, or whatever other accrediting service a facility uses, but it has nothing to do with the Board of Nursing. So we can't answer that question for you.
So just to play that out then, Ruby, in a situation like this, if there is a new workforce that is being hired and deployed to address the needs of the surge, and an employer has a policy in place that says we have vetted the competencies of CPR and this and that for this new workforce, then if that competency has been evaluated by the employer, then the nurse assigning those tasks has no liability in assigning those tasks to the workforce because the employer has already provided that for them.
That is correct.
Okay.
That is correct.
Thank you. Another question that has come in is, while in the pandemic crisis, while Oregon is not currently experiencing extreme care needs, is delegation and assigning to non-traditional healthcare providers allowed if the training and competency is verified? So is this something that can be done at any time, or should this only be reserved for when the workforce is under stress or experiencing a surge, I believe is the question.
Yeah, the answer to that question is no. This can occur anytime. It is not really related to COVID. The one caveat I will say is that the more unregulated individuals you bring in, the less public recourse your patients have. We are currently getting a fair number of complaints about caregivers in organizations that we have no jurisdiction over. And again, because the public thinks that, if it's a nurse, which they are all nurses, even if they're an unregulated individual, comes in, and then if there's something wrong, I'm going to complain to the Board of Nursing. So it's not just about COVID. Like I said in the beginning, this is always been the case. This is the way the Practice Act is currently written. But again, right now we're dealing with an unprecedented number of unregulated individuals being asked to come into the workforce, especially non-essential personnel. So that's why we thought this was a good time to clarify all of this. But long answer to your question, no, this is not just for COVID.
It sounds like at an organizational level, it's that balancing act between how much do you want your licensed staff to be assuming responsibility for under their license versus how much responsibility are you willing to take as an organization?
Again, the organization is at total risk. The more unregulated individuals you bring in, the more the nurse, if they choose to competency validate all of these unregulated individuals, the organization has the ability to do that. You can't call them nurses, you can't call them CNAs, and there's no recourse. Mm-hmm. So the organization takes total and complete accountability for the quality of the care those individuals, unregulated individuals, are delivering.
Thank you. I do have clarification regarding that other question. So this is related to the scope for paramedics working as emergency department technicians. Is there a way to expand their scope in this time?
The thing about this is that paramedics and EMTs, they fall under the Oregon licensing office. However, their scope is pre-hospital only. It's pre-hospital only. So if you have a paramedic or an EMT working in your emergency room, they do not do that under their license or their certification. They can bring their skill set into your ER, but they cannot be called paramedics. They cannot be called EMTs. They're called emergency room technicians, and that is the same. The rules about that are the same as the unregulated healthcare staff. The regulation of their board stops at the front door. Once they decide to move out from behind a rig and go into your ER, they are considered unregulated healthcare staff. They do not fall under the jurisdiction of the paramedic or EMT board.
And it looks like we have one final question here. And the question is, should organizations be referring to staff as unregulated assistive personnel instead of calling them unlicensed assisted personnel?
We have no control over what you would like to call them. The confusion comes with people like CNAs or RTs or some other people that, again, may have certification from a board, but they are not licensed. And the true differentiation is, did they get their education, their testing, their authorization to practice from a legislatively authorized regulatory board, or are they filling a role that is within that organization only? So we cannot tell you whether or not you want to call them unregulated or unlicensed. That's up to you. But again, with the large variety of people that are certified but not licensed, et cetera. And of course, there's such a thing as state certification like your CNAs, and then there's national certification like your MAs. Your MAs may be certified medical assistant, but that means they voluntarily took an examination. It doesn't mean that a board supervises their practice. So it's really up to you. We are trying to clean up our language in the Practice Act to make it easier to interpret the Practice Act. So we have chosen to go through regulated and unregulated, and our language in the Practice Act will start to change as we can revise the Practice Act to go from unlicensed to unregulated. So you can call them whatever you want, but for clarification, the board is calling them unregulated or regulated.
Thank you so much, Ruby. And it looks like that was the last question in our question queue.
Okay, great.
First of all, Ruby, thank you so much for jumping on this webinar and being available to answer these questions and make this clarification. I think it's really timely, and I appreciate your ability to be so agile that you can jump on and you can put together a webinar so quickly. With that, I think we're going to go ahead and close and give everybody 15 minutes until your next video call. Thanks, Ruby. Thanks, everyone. Kelly, thanks, everyone. And have a great Thursday.